My name is Scott Faucett. I'm an orthopedic surgeon with the Centers for Advanced Orthopedics in Washington, D.C. Here to talk to you about meniscus allograft transplantation and the use of FastFix Flex in order to be able to do a meniscus allograft transplant and get adequate fixation using an all-inside technique. Indications for this procedure are basically two. One is a meniscal deficiency, in which case this often happens after multiple meniscectomies or in a large bucket handle that is not reparable, or in the case of an irreparable meniscus tear, in which case there's no suture that will hold in any of the tissue and you need to perform a meniscus allograft transplantation. Meniscus allograft transplantation is critical in the setting of a meniscus deficient knee with an ACL tear, because as we're learning is that some of the forces placed across the ACL ligament are increased in meniscus deficient knees. So always should be thinking about the status of the meniscus in revision settings of ACL. On the first step of performing a meniscal allograft transplant, we want to assess the allograft. These are generally sized using radiographs that have been performed using a magnification ball to accommodate for magnification. Here we can see the medial meniscus allograft, its attachment. You only get a partial of the tibia. And we're going to mark out our resection. And for medial, I recommend using bone plugs. You can do soft tissue only preparation that's much easier, in which you just release the meniscus allograft right off of the tibial bone. We're going to do a small 8mm bone plug. And you also want to orient yourself. I use the word top because it's a word that I can notify the anterior portion as well as the posterior portion, and as well as the femoral and tibial portion of the meniscal allograft. So here we're using an oscillating saw to remove the bone section, and we want to make a long bone tunnel which will trim down to size as needed. Final goal is to have a meniscal allograft somewhere around 7 millimeters in diameter. I'm going to trim off some of the soft tissue here. Again, it's important to label your meniscal allograft prior to releasing this, because it's very hard to tell what the femoral tibial surfaces are once you've resected it. We're going to trim it down to just about 8 millimeters in depth. And we'll use a rongeur or bone cutter, whatever you need. It's really important that this easily goes through a 7, because you don't want to have any difficulty passing these through your bone tunnels. I'll drill a small bone tunnel through the allograft, trying to center this to exit directly out. And we'll use suture that's on a needle here to secure the meniscus in a Mason Allen type repair. Having these swaged mini tapes is very helpful and can speed up the process. So we're bringing this back up towards the femoral surface, being able to kind of get a whole luggage tag of meniscal tissue to control the meniscal root, and then we'll bring that right back down the tunnel there. Make sure that our tissue is secured on both sides. Alternatively, you can use a loop suture on a needle. Can make your preparation a little bit easier. You'll loop the bone graft through the loop and then bring it right back down, creating a luggage tag suture. Now that we have both of our bone plugs secured with suture, double check to make sure that these bone tunnels will go down our appropriate tunnels. Post-operatively, we need these patients to rest their knee. So I'll often place them in a hinged knee, locked knee brace to keep the leg locked out in extension for a full 6 weeks. I allow them to do range of motion with physical therapy, and I like to start physical therapy right away within the first few days to initiate the range of motion. We'll often place these patients on continuous passive movement machines to help work on their range of motion. After the 6 weeks of protected weight bearing with the knee immobilizer, we'll then advance them over to full weight bearing utilizing crutches. This usually takes about another 1 to 2 weeks, so patients are walking normally at approximately 2 months. We'll also begin a progressive strengthening program to work on quadriceps strengthening as well as balancing the hamstrings and quadriceps, and this will take a period between the 6-week and the 3 to 4 month mark. We'll be assessing their range of motion and strength through months 4 through 6, with potential increase to more dynamic activities after the 6-month mark. I usually advise patients 9 months to 1 year prior to returning to sport, And I also advise patients the limitation of this surgery in the sense that this is able to get the patients back to have a stable knee and to be able to do activities of daily living without pain. Any other advanced activities such as sport come with additional risk of meniscus re-tear and need for revision surgery.